Okay, thank you everyone for being here this morning. We're going to go ahead and get started. We're at the Healthcare Services Review Project Committee, and I'll call this meeting to order at 8:31. Annette, can you please take roll call?
Yes. Supervisor Canepa?
Here.
Supervisor Dean?
Here.
Acting County Administrator Regallo?
Here.
Ms. Hopkins?
Here.
Ms. Van Stein?
Here.
County Counsel Kiernan?
Here.
Ms. Macedo?
Here.
Mr. Wolfcamp? Mr. Diedrich?
Here.
Mr. Castro?
Here.
Mr. Nunez?
Here.
Mr. Zuniga?
Here.
Thank you. Moving on to the action items, we have one, the approval of minutes from February 21st, 2024. You've had
Move
a
approve.
chance to review. Oh, thank you. That's Supervisor Canepa moves to approve.
Second.
Mr. Greg Diedrich is the second. All in favor?
Aye.
Motion passes. Okay, moving on to our information and discussion items. And first we have Chris Zuniga here to present the 2024 financial results through January for the county clinics.
Great. Thank you very much. Good morning, everyone. We begin our discussion as we normally do with billable visits for the FQHC. Billable visits for the month were 11,949. We see an upward mobility, a uptick with regards to billable visits, and this is just a testament to all the hard work in recruitment that Dr. Dulio, who sits just next to me here, has done. And I'm happy to say here on March 20th that the trend has continued in February and March, so we'll see that in future presentations. Year to date, we are under budget for billable visits to the tune of 8,621 visits. But as I say, we are experiencing an uptick, and productivity has increased for the FQHC, which is wonderful news. Moving on to the income statement for January 2024. Those 11,000 plus visits resulted in 1.7 million in net patient service revenue against a budget of 1.8, so unfavorable variance of about 128,000. The big story this month, folks, is our supplemental revenue associated with our QIP program. We had a large sort of one-time pickup for both program year 5 and program year 6 with regards to the accruals that we're booking each month. So that was $4 million that is recognized on the income statement for the month of January 2024. We were able to recognize some grant revenue this month, which is good. That's been a sort of a challenge for the FQHC this year, $302,000 for grant revenue. Still under budget versus not only the month of January, but for the fiscal year as a whole. Total operating revenues for the FQHC are $7 million against a budgeted $4 million. So for the month, it's a favorable revenue variance of $3 million. As we extrapolate to the fiscal year as a whole, we're at $31.7 million against budgeted 28.7. So again, favorable year-to-date budget variance of 2.9 million. Any questions as to the revenue side of things, folks? Hearing none. Continuing to expenditures. Not much to report per se, just about an average month. Salaries are in line with expectation, as are benefits. Professional fees, we continue to exhibit professional fee unfavorable variance to budget. We are using locums to produce those productivity numbers we just discussed, as well as other legal fees and other purchase services. But on the whole, total expenditures for the month were 4.3 million against a budgeted 4.1. So not too much different than budget, but definitely on the net income side of things, we're exhibiting 2.8 million in net income against a budgeted, we'll call it break even, modest budgeted loss of 44,000. So just about the entire amount of net income is a favorable budget variance. And on a year-to-date side, we budgeted 500,000 roughly in net income, and we're at 4.2 million. So favorable budget variance of 3.7 million. Any questions there?
I have a question. So where?
Yes, sir.
So, and contracted employees versus, are they in salaries and wages, or how does that work? If you contract out with somebody, where?
Yes,
where in
that would be located in professional fees. Only
Okay.
employees are located in salaries and wages.
Okay, so that $934,000, what's the reason for that? Being
934,000.
the loss on the right, all the way for the professional fees?
Oh, for professional fees. So exactly as I just mentioned, Supervisor Ding, we have the,
Fees over there.
sorry, Supervisor Canepa, thank you. Yeah, right.
I'm the nicer one, just so you know.
Yeah, I
We'll
can
leave
feel
it
it.
at that.
Yeah. So yes, the 934,000 is associated to about 563,000 unbudgeted locum costs, about 285,000 in legal fees. There's also miscellaneous professional service fees on a year-to-date basis of about 106,000. So that explains that variance there.
Okay, so those losses are trending, which way are they gonna go? Are they gonna level, or?
So professional fees, we anticipate will exhibit unfavorable budget variance throughout the rest of the fiscal year, specifically because of our use of locums, which are expensive providers.
Okay.
Do you have the ability to have a pointer or something to show what you're making
Yes,
reference to
we
while
have,
you're doing this? Because most of the time, I don't know where you are.
Supervisor Canepa is referring to this 934,000 on the right hand of the screen.
I mean, because everything looks all right, and then you go down to dues and subscriptions, and that one's still a lot of whack.
So Supervisor Canepa, that will improve, and the reason why is we are still utilizing locums, but we've signed an MOU with Health Plan of San Joaquin, which if these locums are strictly seeing Health Plan of San Joaquin patients for gap closures, they'll reimburse up to $10,000 a week, up to 3 locums. So that will decrease, but we are still utilizing locums.
When did that start?
It's going to start April 1st.
And that, in the subscriptions you're advertising, is that counted in there? Brought to you by San Joaquin County?
No, advertising, we do have 40,000 for the month that we recognized, but dues and
What category do you put that under?
advertising and promotions.
Am I looking right at it?
I will use this here. Advertising is just above travel.
Got it, thank you.
You bet. For dues and subscriptions, the unfavorable variance there is largely associated with software that we purchased last fiscal year and capitalized and are now sort of amortizing over this fiscal year. And so those purchases were covered under grant funds last year. We recognized those revenues last year, but that accounts for what we're seeing in dues and subscriptions. Thank you. You bet. And if I go to the next slide, This variance explanation sheet describes in detail sort of the year-to-date explanations for both positive and negative budgetary variances. We are still running, for example, a very large budgetary variance with regards to employee benefits, and we anticipate that will last throughout the fiscal year. We were forced to budget with like 66% benefits for all employees of the county. So those that we ourselves have, and then that we purchase from, say, the hospital or BHS and what have you. But the actual is coming in at like 43% as the description says here. So feel free to examine those variance explanations. I'm going to move on to the balance sheet. Balance sheet continued to be strong. We have cash in the neighborhood of 20 million as we have all year long. Other assets have grown to 20 million from 17.8 in the previous quarter. And that's largely due to our QIP pickup that was mentioned on the P&L earlier. Our total liabilities are 9.3 million, 9.4 million, and net assets are coming in at 35, call it 36 million. So total assets equal total liabilities and net assets at 45,300,000. We still exhibit about $3 million in restricted net assets associated with unrecognized grant funds received. And we are still working with our grant teams to be able to recognize those funds as revenue. Cash collected, we're reflecting 1.7 million in cash collected for the month of January 2024. Again, this is highly correlated to our billable visits, and we'll see that in the next slide. But as we saw an uptick with billable visits, so we see an uptick in cash collections.
I have
And
one
that's
quick
further,
question. On the billable visit, what was the high? I saw 13,000.
Yes, sir.
You said how many were that you were short by how many visits? The
On the
budgeted?
year is about
Oh, the year, okay.
8,600.
So 13,000 is the max ever, or is it higher than that?
You know,
in the past?
it's been about the 13,000 has been the max ever. And if we go back, I think we reached that a couple of times.
Sorry, I scrolled.
No, that's fine. No, this is fine. In March of last year, 2023, and then again in August 2023. So those were the highest billable visits in the history of this FQ.
And you're budgeting what rough number was what are you budgeting monthly? Because you said you were 3,000 short, so we're at.
So
what's
on
the
a
range,
year-to-date basis,
11,500?
on a year-to-date basis, we have budgeted 86,000,
Okay, there it is. Okay, perfect.
and we have actual visits of 77,380. So we did take a hit, or we saw a downward trend rather, between September and December of last year. But it is really looking like we are recovering from that dip due to our recruitment efforts. And again, Dr. Dulio.
So 86,000 divided by 12, so 7,100 is the base monthly?
No. So that's divided by 7.
Oh, so far.
So you're gonna get a number somewhere between 11 and 12,000.
Okay, 12,285.
Yeah, somewhere. Yeah,
Thank you.
you betcha. And again, this is just a depiction of how highly correlated, and Sandy, you're here for the first time, so I sort of forgot that in my presentation. I wasn't going very slowly. What we're depicting with these charts is 3 years' worth of visits as well as cash collected. And you can see they are highly correlated, which is what you want to see. You want to see that you're doing business and collecting for it. So these are HRSA metrics, Health Resources and Services Administration. That is the federal regulatory body that governs FQHCs across the nation. We're required to report these statistics from a financial perspective to our board of directors, and so therefore they're included in our presentation. The cumulative cost per unique patient, again, will get more robust as we approach June. But that currently sits at $1,037. Medical cost per medical visit, now this is a pretty robust number in and of itself. This is telling us how much per visit it's costing us to operate. So that's about $360 per visit. This chart is a benchmarking chart. There is a nonprofit that benchmarks FQHCs across the nation. They're called Capital Link. They have supplied the first 3 columns in this matrix, and the 5 sort of statistics that they suggest evaluate the financial health of an FQHC, federally qualified health center.
I know.
Okay.
I'm very familiar with
All right, all right. That's awesome. Operating margin as a percent of total revenue. Their target is greater than 3% for a healthy FQ. Bottom line margin is the same. Days cash on hand is greater than 45 days. Days in net patient receivables, they're targeting less than 60 days. And then your labor cost, inclusive of all contractors and whatnot, your labor cost as a percentage of operating revenue, they recommend that you function at less than 70%. So the net.
Repeat that?
Yes, sir.
Just that last
Absolutely.
part.
The last part is labor cost, Supervisor Dang, as a percentage of operating revenue for a federally qualified health center. Their target is less than 70% of operating revenues is what healthy
Really?
FQHCs should operate at. Correct.
Huh.
Yes, nation.
Seems high to me.
Oh, does it? Yeah, so it's, we're, just like the hospital, so we employ employees that have high salaries, and a lot of them. And it's the most important, or excuse me, the largest piece of our P&L on the expense side are sort of these labor expenses. And the FQHC industry tends to be, and healthcare in general, tends to be expert-oriented. Like, we're always hiring consultants. So that goes into that statistic as well. But as the next 2 columns are the 2021 national median and 2021 California median for all 5 statistics. And then the following column are our fully audited fiscal 23 results against those metrics. You can see how similar we are to the 2 medians. And then fiscal 24, the fiscal year that I'm currently reporting, is the highlighted. And so for operating margin, we're well above the target at 13%, but not unlike 23 results and the medians. Same for bottom line margin. Our days cash on hand are a healthy 160 as of January 2024. And then days in net patient receivables are a healthy 31 days, which is a stark contrast to where we were when I first got here. It was very, very different.
I do have a question.
Yes.
If I could just ask, so on the national and the California median, are 2021 the last?
That's the
data
last
that we
set
can
of,
get?
yes,
Okay, because
yes.
it's a
So
little, I understand what you're saying as far as the health, our SJ Health,
Yes.
currently audited 2023, but that's 2 years difference. So I was
That's
just
correct.
wondering if you had anything.
Yeah,
after.
Capital Link has not released the California numbers. And I'm told that for 2022 now, not even 2023, For 2022, the national numbers are on the way. California will be another few months.
Okay, and that would be, and I probably, I'll get more familiar with this, but
Sure.
Do you report on this every quarter, every?
Oh, I do this every month. We
So
do
then
this every
if,
month.
whenever we get the 2022, then you'll compare the latest with the 2022?
Yes, ma'am.
Okay, just so that we know.
Exactly right.
Okay, thank you.
Our personnel or labor as a percent of operating revenues are at 71%. So on the cusp of hitting that target, but still have work to do. We have closed February, so I know as of our February report, we are all greens for that whole column. So happy to report that as well. That essentially concludes my presentation of our financial results for January 2024, unless there are additional questions.
Seeing no questions, we thank you, Mr. Zuniga, and we'll move on to the next presentation, which is from Abe Nunez, and he'll present the 2024 financial results through January for San Joaquin General Hospital.
Good morning, everyone. So we're going to dive into the hospital's January financial results. Overall, from a bottom line perspective, we did experience considerable improvement compared to where things stood last month. Some of you may recall that our budget deficit was hovering around $2 million through the first 6 months of the fiscal year. When we fast forward to January, that variance has come down to $360,000 from a net income viewpoint. When we look at our results from a cash flow perspective, we're favorable to budget by $300,000. The key driver for the improved results were some one-time pickups connected with our incentive programs. This month, we were able to bring in some revenue associated with the voluntary rate range and enhanced payment program. And this was associated with 2022 service dates. So that's the good news. The not so good news is that our volume trajectory continues to trend below where we planned this fiscal year, in particular when we look at our adult inpatient business, along with our ED visits. So when you look at our inpatient days, discharges, along with those ED encounters, those volumes have contracted year over year and are short of our target. When we quantify the revenue impact connected with that volume decline, it's anywhere between $5 to $6 million annually. So fortunately for us, we've been able to offset that lower revenue associated with our day-to-day operations with higher incentive payments. But what that means for us as we close out the fiscal year is that we have to proceed with extreme caution and really evaluate the return on any new resource that we bring on board at the hospital. Okay, so when we look at volumes for the whole house, looking at our adjusted patient days, which is our inpatient days plus outpatient equivalent days, you can see that we're short of target by about 2%. Some positives on the volume side, our maternal child department continues to trend in the right direction for us. Our deliveries are better than budget in prior year, along with our outpatient surgeries and clinic visits. So those are trending in the right direction. The acuity level of our patients looking at CMI has picked up year over year and is better than target. So it's great to see that we're seeing a return on the clinical documentation improvement program that we established at the beginning part of this fiscal year. Overall, when we look at revenues, we are $3.7 million or 1.3% better than budget, and that's due to the favorable budget variance associated with our incentive programs, as mentioned. And then on the expense side, overall, we're $4 million, or 1.4% over budget, and that's connected with our travelers. We set a very aggressive target in traveler reduction in anticipation of hiring international nurses, which hasn't materialized for us. And then when you look at our overall cost structure for the hospital, looking at our cost per CMI adjusted discharge, so that's our cost per volume indicator normalized for acuity. We're a little bit above where we expect it to be by about 0.5%. we were trending very well through the first 5 months, but over the last quarter, I would say, our length of stay has increased, which has impacted this metric negatively, along with the lower discharges that we've seen here in the last 3 months.
So I don't understand what that means, the case mix index.
So the case mix index is an acuity measure, and I'll give you the easiest example, it's pneumonia versus sepsis. If you code
okay.
correctly, right, so, we weren't doing that when we first started this endeavor, our case mix index was that of a very basic community hospital. When you look at our trauma services, we realized that wasn't the case. We worked hard on the documentation points. So that increased revenue from documentation alone represents millions of dollars to our bottom line. So we're doing a much better job on how we actually bill and code our encounters.
So all that gobbledygook on inpatient days, can you explain kind of that?
Gobbledygook?
Yes.
Ouch.
There's a lot of little information in that, the Medicare CMI versus,
Go back a slide.
Sure.
in plain English, what does
So
all that mean?
historically, we left a lot of revenue on the table here at San Joaquin General by not.
'Cause they were coded
By
wrong.
not, exactly,
Okay.
exactly.
Okay,
So now that we have a CDI program, we're evaluating all our inpatient discharges to ensure that we're getting reimbursed appropriately for the level of care that we're providing.
so on that, so what's the number that you're trying to get on that? The inpatient days, so,
We're trying to hit budget in terms of our volume metrics. Is that the question, sir?
yeah.
Correct, yeah, so.
And you said, well, deliveries were up, so you said those two variables, I mean, so that's what,
So we're 2% on an
see, one thing
inpatient.
you're saying coding is the problem, and then you just said,
No, on the inpatient side, our volume is down 2%. And when you try to predict inpatient volume, there's two factors that are really challenging in this time. First and foremost, for 2020 and 2021, COVID threw off everything, right? All the numbers that we saw before were completely changed because of that, the mass volume that we received there. So that's the other piece for us is from a capacity perspective, even though we're falling short of budget, we're every day over capacity in the number of patients that we have versus the beds. So that's gonna continue to be challenged going forward. To continue to grow volume in a place where you don't have beds is gonna be a challenge going forward as well.
all right, thanks.
Yeah, so by coding our services appropriately, we've been able to offset some of the lower revenue associated with volume decline. So here's the condensed version of our income statement for the month of January. Very, very strong result, but again, largely driven by the one-time pickups connected with our incentive programs. One positive on the expense side is that we were favorable to budget or lower to budget for the month of January. So that was great to see. And when we look at our traveler expenses, while we are over budget, that negative budget variance has continued to decline over the last 3 months, especially, meaning that we're filling those vacant positions.
And if we can keep the nurses that we've just hired, over the last 2 months, we've added about 70 nurses. That should take all those travelers completely out of the mix. The challenge that we continue to have on a lot of our new hires is experience and leave. So we talked about.
Can you speak up a little bit?
Where do I start? Where do I go back to? Okay.
Just about having trouble keeping the nurses.
So we very fortunately just added 70 new nurses to the hospital, which is a huge number. Of those 70, probably 68 are brand-new grads, right? So that's the challenge, and when you look at places like our emergency room, as we funnel these new employees through, they're being trained by people that were new grads 6 months ago, which is not ideal. So we talk about that scenario with in the union contract, where we really want to make sure that we look at that opportunity to say, how do we did an employee survey. We really found out that after 5 years, we're really good. After 3 years, we're pretty good. But 1 to 3, we're really, really bad. So how do we address that issue in regards to getting our own staff? Because when you look at the forces coming against us, those traveler dollars have to completely go away. We have to do it with our own staff. And right now, it looks favorable, but we've been here before, and we continue to lose a large number of them after they're trained. Now, I guess the kind of good news, bad news is, we do see a significant swing in the nursing labor pool. A lot of people have made significant progress on their travelers, and why that's so good, it's less options for those people to leave so people are hanging in there a little bit longer, which helps us.
So here's the more granular version of our income statement. So comparing the first 7 months of this year versus target and also prior year. When we look at our gross patient revenues, you can see that we're 1.4% better than budget. I do want to point out that that positive variance is all on the outpatient side. As mentioned, our inpatient business has contracted. What's important to note there is that there's a considerable difference in our collections rate between inpatient versus outpatient due to how our contracts are structured with the various payers. On average, we collect 14 cents on the dollar for inpatient services, whereas outpatient, we get 8-9% on average. So that, I point that out since that's what's driving the unfavorable variance when we look at our net patient revenue.
So just a point to be made there, the reason that the inpatient is over is significantly higher in percentage is because it is the one place that we are not straight Medi-Cal, or not Medi-Cal or Medi-Cal managed. The other piece of it, in any other hospital, the goal is always focused on outpatient because that's typically where you see a much better revenue source. That's not the case for San Joaquin, which is just a different strategy. You have to think differently, like when you push the outpatient business, if you're, if you know your collection rates are going to be in the 9%. So.
And CAPH is aware that, hospitals are seeing less inpatients and more outpatients, and they're working with the state on getting us higher reimbursement rates for outpatient services. But that hasn't been officially blessed yet. That's still in the works. When we look at the expense side, you can see that we're $4 million unfavorable to budget. And that's all essentially in the professional fees where we book the costs connected with our travelers. I do want to point out when we look at our expenses year over year, this year our costs are at $290 million. That's for all categories. Last year we were at $276 million. So we're up about 5%, which correlates with the higher salaries that are hitting our books connected with the MOUs with the various unions. What that indicates is that outside of that inflation in wages and non-wages, we're doing an admirable job holding the line on our cost structure. Here's the balance sheet. The one item to note is our cash balance has declined considerably year over year, and that's due to the timing of the incentive programs. We expect a cash inflow of roughly north of $100 million by the end of the fiscal year connected with our incentive programs. So a sizable payment we're expecting from the voluntary rate range, the QIP, along with the enhanced payment program. So that cash will hit our books, our balance sheet before the end of the fiscal year. This one's kind of an eye chart. We'll reformat this with 5 or 6 key metrics. Here's our key volume graphs. The top section, that's our adult inpatient business. Blue line's current year, red target, green is a prior year. When you look at our patient days, which is at the top left, you can see the blue line has consistently come in below prior year. Same with our discharges at the top right. At the bottom left, you'll see our length of stay. We were doing a good job staying within budget through the first 4 or 5 months, but that's crept up here in the last couple of periods. And Rick and I did have an opportunity to meet with our case management team yesterday, so I know they're working diligently on ensuring that we're discharging those patients as soon as they're medically cleared.
I think it's important to call out, though, one of the big issues that we're having is kind of the final ground for patients that nobody else can take. I'll give you that. We have a 4'2", 560-pound patient that we can't provide any more services for, but we can't find anybody to transport her back up to her apartment. And truth be told is if we transported her back up into the apartment, they'd probably have to come 3 days later and transport her back down. So we have, we looked at 15 patients over 12 days yesterday, and some of them required that length of stay, but we had about 4 outliers that were in the, one of them in the 300s. And sometimes, guys, there's just no answer. We have a family that refuses to take a patient from a different country back. They have no services, no payment source. And of all things, the family keeps telling us they're gonna sue us. They could take your family member home, right? It's just, so that's something a little bit different in a safety net hospital that you wouldn't see at a St. Joe's, you wouldn't see at a Dameron, you wouldn't see at a doctor's. And the challenge for us is that catchment area, because there's no public hospital in Stanislaus County, that catchment area becomes bigger and bigger. So that challenge has to, there's certain questions that you don't have answers for. And that's one of them that I don't know how we'll handle if that volume continues to grow.
I have one. So on the average length of stay, how do you budget that? That line moves throughout the year.
Well, you budget it by looking at what you want it to be. You look at all your diagnoses. They all have a mean length of stay. You use that mean length of stay to dictate what it could be. And then there's some opportunities, like oftentimes you see we have a larger volume than anticipated of labor and delivery, which is a good thing. Their length of stay is very, very short. So when that volume goes up, it's gonna bring the overall length of stay down. So it's really just a determination based on the diagnosis codes, but for it to be exact, the numbers would all have to be exact, right? You'd have to hit the exact numbers for it to be there. So it's just a gauge to say we're keeping our patients too long or we're not.
Okay. Yeah. And then, so on the traveler part of it, so then last year it was at 50 million. So what's the goal? Are you guys on task to hit that? You're at 36 now. I mean, so is that what your benchmark was for this year? To get it less than that, 50 million, or how does that work?
Correct. This year, I think we set a target of 55 travelers. Yeah, there's a slide here that we'll share shortly. That shows it.
Before we move on, sorry, I also had a question. So, and you had said you wanted to improve on the average length of stay by, I guess, releasing the ones that have been medically cleared. Right now, are you, I guess, keeping patients a little bit longer than, they're medically cleared, and what's happening, why aren't they being released?
Yeah, it's a challenge, as Rick alluded to, Sandy. Some of our patients use us as a hotel room. He gave the example.
So in those types of situations are
But
what you're
every
talking
day,
about.
the goal really is the minute the patient crosses the threshold to inpatient, we should have a planned discharge. And and because we have physicians staffing the hospital 24/7, we should be able to hit our goals. The challenge really becomes the social barriers that are significant with our population, right? So do we keep a person an extra day who has a healing wound because we know we're gonna discharge them back to the street? So is it better to keep them that extra day even though you're probably not gonna get paid for it? Or send them out and risk well, first and foremost, best care of the patient, always the focus. But the challenge might be that he'd be back to you in 3 days for another 10-day stay that wouldn't be covered at all.
Okay, so as a follow-up then, because I didn't understand that those were the only ones. But, so the ones that, if they don't have issues like that, they are being medically cleared and released.
Our utilization review team is working closely with our providers to ensure that we're starting that discharge process earlier in the day to impact that metric.
Thank you.
But as all hospitals, there's always an opportunity. The ideal scenario would be just like a hotel that everybody was discharged by 11 o'clock, but it's a challenge.
Yeah, thank you.
Okay, so here's some additional volume graphs. So surgeries on the top, that's been a good story all year. Our outpatient surgeries are trending in the right direction. Bottom left, trauma volumes, they did pick up month over month, but you could see when you look at the blue line, still considerably below where we expect it to be in this year's budget. And then looking at ED visits, we have picked up over the last couple of months relative to the first half of the year, but still not where we expect it to be in our plan. Here's some metrics associated with our billing and collections operations. Overall, when we look at our cash through the first 7 months of this year versus the same time last year, we're up about 1%. But as mentioned earlier, that contraction in our inpatient business and ED volumes, that's roughly $5 to $6 million in lower revenue. So that 1% would be closer to 2-3%, if it wasn't for that volume decline. And we continue to work with the Cerner team, the whole revenue cycle team there at the hospital, to ensure that we're figuring out ways to optimize our EHR setup. So leveraging those work lists and work queues to try to eliminate any manual processes. Here's a slide that measures our days cash on hand. You can see we've come down considerably, but we expect a cash inflow of roughly $108 million here before we close the fiscal year connected with these supplemental programs. And here's the case mix index or acuity level of the patients that we discussed earlier. Medicare and CDCR are the two payers that reimburse us based on the weight associated with those inpatient discharges. And you could see the considerable improvement year over year and even going back, to 21, 22. So now that we're improving the coding of those inpatient cases, it's reducing our denials from our payers and ensuring that we're not leaving any revenue on the table. Here's a slide which measures the overall cost structure for the hospital. So it's our cost per CMI adjusted discharge. So it takes our total expenses per volume measure normalized for acuity. This year we set a target of 15,400. Our actual rate, we're actually running at 15,496, so slightly above budget, but better than where we ended last year. And the increased length of stay has impacted this metric negatively over the last 3 periods. So the blue line is actual, red is target, so we want to be below the red line. That means that we're staying within our allotted budget based on the acuity level of our patients. And then we talked about the travelers earlier. So here's a slide that measures our contract labor FTEs. You can see in the month of January, our travelers, which is the blue line is current year, orange is prior year. We decreased by 70 travelers or 40%. And you're seeing that in our income statement. When you look at our professional lines year over year, our professional fees are favorable by about $9 million. And it's really 10 departments that's driving those contract labor FTEs. But we, as Rick alluded to earlier, we expect that this number is going to come down even more and get closer to target as we onboard the new grads in our clinical departments.
And what we'll do next time is show you a slide of nursing, because nursing is where the big dollars are. When you look at the bottom of his last slide, and you look at EVS and dietary, and I mean, they're low-cost fill-ins. It's not what we want, but they're low-cost fill-ins, and dollar for dollar, we're probably, by the time you include benefit costs, we're probably not spending more. So we'll focus on the travelers that really make a difference. For us, that would be nursing. At this point, we don't have any locums, but we put that in that box as well.
And if I'm reading this right, 1/3 of our traveling nurses is emergency room.
Correct.
I have a question on the previous slide. So in November, that 16,000 number that was so high, you're saying that was because people stayed in longer?
Correct.
Right? That they possibly needed, so it was a decision to stay, possibly to keep them
I think
out.
it's cost overall, isn't it?
Yeah,
It's cost
it was a
overall.
soft volume month in
Yeah.
terms of our discharges. So hospitals in general have a high rate of fixed cost. So when our volumes dip,
That number
then
goes
it's-
up. Okay.
Exactly.
Okay, thank you.
And here's the dollars associated with our contract labor. Our high point was during the COVID period in 2022. Hospitals were hard pressed for resources. You can see we're at 82 million that fiscal year. Last year, we improved by about 20 million in aggregate, came down to 63 million. And this year, we expect to come in another $20 million lower than where we ended last year. So So definitely trending in the right direction. And in terms of opportunities, right now we're in the ballpark in terms of achieving our bottom line projection. Some of the items that can help us close the gap potentially are the QIP quality metrics. I think we all agree that there's an opportunity there, right, to ensure we're not leaving any revenue on the table. The EPP supplemental program, we got some good news from CAPH. They were able to negotiate a 25% increase starting January, so beginning January of this calendar year. For us, that translates to about $4 to $5 million incremental revenue. As we go forward, we've been advised by CAPH that the funds connected with these incentive programs are going to be tied to cost measurements. So identifying opportunities to realize efficiencies will be critical. Otherwise, we're going to leave revenue on the table connected with these programs. We were able to negotiate a 7% increase from the health plan of San Joaquin. That means that's roughly $2 to $3 million in higher revenue in the last 6 months of our fiscal year. We talked about the certain revenue cycle uplift project, finding opportunities to automate processes so that the teams can focus on working those high ROI accounts. That's on the revenue side. On the cost, continue to find opportunities to rationalize the number of traveler nurses will continue to be one of our initiatives. There's a supply savings potential system that our Director of Materials Management is evaluating. So that's going to help with par level optimization of our inventory. There's going to be some productivity improvements, and we'll have an automated way of tracking our high-cost supplies in both our OR and the cath lab space. And the reference lab savings continue to ensure that we're not sending out any unnecessary lab tests to Quest. So looking for ways to reduce that expense.
So the reference labs has a second piece to it. In the unfolding of the hospital and the clinics, capitation contracts changed, and unfortunately the hospital. So we took a 200,000 people and we kind of shared them between two labs on a capitated basis, which is really a bad idea. And the net to us is about a $2 million, so we're working on that. A couple of things that are really important for us when you look going forward. We have to have some leverages as a hospital that are industry standard, but not necessarily county standard. So we talked about, and we're making significant progress on getting an absentee policy. We told you guys last time that we looked at our long-term sick, in our people that have been there a long time. You would expect those hours to be in the hundreds, if not closer to the thousands, and we find them in the 20s and the 30s. So in the hospital, the perception of sick time is that it's PTO. And if you understand, the challenge of that is really significant because for everyone, and again, I'm going to say this again because I think it emphasizes what we need to do and how we need to change the culture. We had 42 nurses call in sick on Halloween, and Halloween is not even a national holiday, right? And it's really hard from an organization that's so focused on taking care of the public to understand that we have employees that would make that decision. It's just the wrong thing to do. But understand that we replaced 42 nurses that day. Best case scenario, all at time and a half. So sick time becomes operational. You add the time and a half. We're paying 2.5 times each employee. We did a very down and dirty analysis of our sick calls versus what would be the standard in the outside, and we believe that the dollar figure is about 15 million. 15 million. So we've been working on an absentee policy. I think that as I'm talking to other people in the county, I don't know that the problem exists as significant as it does in the hospital or exists at all. But I think I think we need to make a point that sick time is sick time, and it's not PTO. And I'm bringing these up because if we don't change some of these, when we look at our organization and we look at the challenges that we have, we almost have to hit every pitch to stay in the black. And we don't have the leverages. The other thing is we don't have the ability to flex. We've been fortunate where beds are full, so that hasn't become an issue. When we had these conversations back in 2022, the request was we need to run the hospital more like hospitals, and we need those levers. It's really important for us, or we're gonna start seeing a continual negative, our budget that does not operate in the black. So the potential is there, but we have to have some leverages to make that happen. And I think that's probably true in the clinics as well.
Absolutely.
Yeah.
To piggyback off Rick, it's very similar with not so much the nurses, but more medical assistants, right? So Monday and Friday, the amount of call-ins is astronomical. So, you know, a lot of 3-day weekends and 4-day weekends
Sure.
with their staff. And
Yeah.
I would love to work together, come up with a policy that kind of benefit
Yeah.
both the hospital and the clinics.
Yeah, absolutely.
Yeah, we've been very fortunate that we've been able to recognize some one-time pickups over the last couple of years on the hospital side to stay in the black. But going forward, it's gonna be critical for us to identify savings opportunities, and the time and attendance policy can go a long way.
So the hospital's bottom line has been affected by the travelers. So I mean, whatever the loss is annually is how much over budget usually that goes.
Well, I don't
I mean,
think,
there's a lot of variables, obviously.
Yeah.
You said the coding is one, you know what I mean, and a policy. But I mean, and then the quit money that's left on the table. So I think that's the most important part, is working together.
Right.
To, you know what I mean? If we can get that quit money up, then sharing it becomes less of an issue.
right.
You know what I mean? So I think it's collaboration, because if we're leaving money on the table and everyone wants the quit money, but then we need to do a better job at least trying to procure it, right?
Absolutely, yeah.
So-
Again, we need to maximize, and you know, most clinics do. So when you look at the public hospitals that are associated, I think it's 16 out of 18 are at 100%. And that's what we need to do from the county's perspective, from the hospital's perspective specifically, but from the county's perspective. And the other odd thing that I find is the trend is the way that they determine safety hospitals are gonna exist is through public funding. You kind of think, why don't you just increase our rates? And we wouldn't have to do all this, right? But it's all through public funding, and the increases that we see right now are significant. What was it? EPP is 25%?
25%.
I mean, those are big numbers when you're talking about millions of dollars. So we have to, you know, pull that extra 20 million, 25 million out that is possible at 100%.
And to cure this, you know, policy on leave is absenteeism is essential. Maybe a line in there, professional, unprofessional activities as a percentage. And it's not like these nurses, I mean, in the other industries, you can require them to go get a doctor's note, but I guess that would be
They
much
work in
easier.
hospitals. There's a
Yeah.
doctor on every
So
corner.
that's not much of a disincentive. They can get that over lunch. But yeah, that's a huge.
I think
Huge
it's
stride.
culture. You know, when you look at what we're trying to do, we all have to operate the same way, but more importantly, I don't want a staff of people that choose to call in sick on Halloween. I don't want them. Because what we do is too important. I mean that. So that culture, and I don't think that that's the general consensus. I think some people just kind of fall in line because everybody around them are doing so. But it's really the win or loss for the hospital. If we can't convince everybody that they need to come to work, do an 8-hour job to the best of their abilities, taking care of people, seems pretty routine, but we're not there yet. And that opportunity is, to be honest with you, the win or loss in the end of the day. So if we can convince everybody, but if we could have some levers to help convince them, then, you know, I think we're gonna do well. And if we can't, then it's gonna be a struggle.
So my question, a lot of it has to do with management. You know what I mean? And how you obviously manage those people, because it's culture too. So how do you change the culture, number one? And how do you go forward? Because obviously there's a bunch of different variables that you touched on that affect that, whether it's time and a half for the travelers, the sick time problem. So what is a goal? I mean, that's obviously what you need to figure out, what the goal is and what the projected savings possibly could be. So that it's something that's sellable, because when you tell it to me, I don't understand, you know, what the swing in those people do to that time. I'm looking back at the one chart in fiscal year 2022, it was up to 82,131. And now you've got it almost in half. So I mean, what's the goal for, you know what I mean?
If we had 5 nurse travelers, just based on things like maternity leave and things like that, that's a reasonable expectation for a hospital that employs about 2,000 people. The other ones, when you look at the, kind of the dietary, you know, we want our own employees, but there's not a financial cost to it, so it's not a big of a deal. But,
6?
well, I think the number for nursing is,
111.
the number of nursing is a lot less than that. So I think there's about 30% of those that are dietary and EVS and things like that, which is dollar for dollar not any different, right? So the goal is, from a nursing perspective,
Oh,
is
so that
probably,
111 number's not, so.
is not all nurses.
30%, so 30 people.
Yeah.
So that goes down to 71, and 71's nursing.
Yep,
And your goal is to get to 5?
My goal is really to get to 0, but I'd take 5.
Okay.
And I think it's realistic, because when you look at what we've just hired, I mean, think about that 70 are on board right now. And as soon as we train them, if everybody stayed, that number would be right where we need it to be. So it's that challenge of making sure that we keep them. And, you know, the nice part about San Joaquin General, the experience that people get when they come there is that of a really high intensity, high acuity hospital. They see things in a very short period of time, especially our ER people, and maybe that's why some might scare. We talk about the day that we had 22 traumas in a 12-hour period, 6 gunshots, 4 stabbings. The only other places you experience that are Chicago or Fresno, or, I mean, there's certain places that have that kind of volume of acuity. And so the experience for our people are really good, but they have to be, and a lot of nurses that choose ER, that's why they do it. But sometimes that's also a reason that people may change course really quickly, so.
Yeah, when you look at the income statement for the hospital and combine salaries, benefits, and the professional fees where we book the travelers, those expenses make up 75% of our total cost. Year over year, when you combine those two categories, we're about 5% higher this year than we were last year. Meaning that outside of the salary increases, we're doing a good job vetting any new traveler that comes on board at the hospital, and only filling those critical gaps in our operations with an outside worker.
And I think the other point that is causing us to be challenged is the cost of orientation. So when we bring on 70 nurses, it's great news, but it's 4 months of non-productive cost and an added burden to the people that are training them. So that's why keeping them is so important.
Thank you. Are there any other questions? No? Okay, seeing none, we'll move on. The next topic is the proposed committee format change, and Brandy Hopkins will be presenting.
Thank you. Thank you, Ms. Regallo. The committee may recall that at our last meeting, a few committee members discussed perhaps changing the format of the Healthcare Services Review Committee meeting, the meeting that we're in today, in order to make them more productive and address other topics outside of financials every month. So you might recall that some of the questions and comments were, every month we go over financials, we have our committee comments, but we're not really focused on the things that drive value to the community and to the patients that we serve. So what we want to discuss with the committee today, to get full feedback from everybody in a more formal manner, because this was during committee comments, is perhaps moving this meeting from a monthly meeting to a quarterly meeting. And that would allow a subgroup, which I'll show in a minute, to focus every month on those drivers of community care and impact to the community and our patients. So we still would discuss financials, maybe in a more condensed version and perhaps a little bit more synchronized, so that the charts that the board members and the committee members are looking at are similar between all 3 departments, to help with continuity of understanding. We would be discussing recruitment and retention and some of the initiatives of how physicians and our medical staff support both the clinics, the hospital, and healthcare services, really driving community care, talk about collaboration meetings, and update on department accomplishments. If we move to this format, what we are proposing is that, again, the monthly work group meetings would consist of the county administrator's office, the hospital, healthcare services, and SJ Health leadership. And then we would report back to this larger committee under our open meeting format quarterly. But again, we'd be focusing on recruitment and retention issues, collaboration, and driving community care together. So I'd like to open it up. I already see Mr. Castro has a green light and his hand up.
Oh, green light,
For your
yeah.
feedback, that Abe can make bread if, just, but I would actually like everybody's feedback so we can decide how is this meeting most worthwhile of everyone's time and focuses on our community and the population that we serve. So, Mr. Castro, would you like to go first?
Sure, I like it to go quarterly, and I think from the supervisor's perspective, just from value of time, you don't see these change dramatically month over month. And we'd like to use the other opportunities to actually strategically plan. And the only thing I would ask is, can we, in the other meetings, can we include the health plan?
Yes, we can.
Okay.
As
So
long
those
as
would
the
be-
rest of the group, I think the group will concur with that, but we'll get their feedback as
Okay.
well.
That's my feedback.
Are there any other committee members that would like to provide any feedback?
Brandy, I'm very much in favor of
Thank
this.
you, Greg. I can't see you.
I think we've had some collaborative meetings with hospital leadership on recruitment. We met with the residency program, but I think the staff level meetings might be structured monthly in this format, but I think we need to have more of those face-to-face meetings to rebuild the partnerships and really to exploit. There's a tremendous amount of opportunities we have available to us if we come back together, more integrated, a lot more partnerships and not have this artificial divide.
Who sets the agenda? I mean, I don't mind. I know it's more work for you all to come. I don't mind coming monthly. So just, I want to know what's going to go on in the meetings and figure out who's talking to who. Because obviously if we're part of it and then we're not part of it, this subgroup, neither one of Ding or I kind of have a problem with that. So we look at the dollars all the time, and it's kind of alarming, like you said, how do we worry about patients? And I hate to see a patient as a dollar, but I mean, when you're bleeding as much money as it has done, and then holding people accountable, I don't know that we know all the specifics, but when these two entities split, how we make sure as an elected that the tax dollars are getting spent correctly. I know we go, it's not, I mean, the QUIP money or whatever, it's still tax dollars and money and revenue. And I think it's important that we're all accountable to how they're spent, whether it's a contract employee. Just because the money is there doesn't mean that we need to spend it. And I think that's the important part for me is, seeing both of these and, the uncertainty with the clinics and the board members that I've been talking to on that side is the lack of information that was getting to those people, to me, is kind of alarming. And I think when you have lay people on boards, they need to be more involved all the time. And whether it's good, bad, or ugly, the information needs to be shared so that we can fix it. And I think that's what's the most important. So, I mean, I'll support this because your guys' professional time, spending an hour and a half here monthly, could be spent somewhere else better. And I think I'm for it. But at the same time, I want people to be more accountable for what they're doing in their organizations. And that's why I think these are important, so that I can look you in the face and hold you accountable for the job you're supposed to be doing, as opposed to, what is actual, because I think the communication skills haven't been good, and I don't know. I mean, this meeting hadn't happened in a year. That's pretty alarming. I mean, for doing the people's work in public is not okay for me. So if it is, then I want to know more of what's going to go on so that it's something that is going to fix the problem. Because these numbers, I mean, we kind of go and we go and we go, and it's not in budget, and it's this and it's that. We need to fix it and make sure that I could sleep at night, because some of these things are pretty alarming and need to be fixed. So I'll leave it at that.
Supervisor Ding? did you have a comment?
No, I'm actually excited about the changes. I agree with the supervisor. We have to be accountable and in the know, but I mean, to me, working groups, that's where you can get together and figure out how to fix the problems rather than just tell us what went wrong or what you think's gonna happen. So no, I think it's a proactive move and I applaud you for doing it.
My only comment would be that, the challenges for all of us in a Medi-Cal environment or a public hospital environment, it is really critical that the system works together. One of the reasons I came here was the system was here, and yet it sits in silos. So we leave things on the table because we don't have direct communication with people from my perspective who all should be on the same team, including the health plan. And never in my professional career, when there's something as important as these dollars on the table, quality and everything, have we not sat down and had a strategy plan with everybody involved to make sure that we understand it better from a whole? And then, we can come to you guys and say, look, this is how it's gonna pan out. It might be different for the clinics, it might be different for the hospital, but understand overall, we're gonna not be a burden to the taxpayers because we shouldn't be. And this is how we're gonna do it, and, with your agreement, we do it that way. So I think the value of, Greg and I and Dr. Dulio and Lizette and the CMOs getting together will help us in so many ways, basically also looking at, we just made an offer to a pediatrician who's gonna serve, we hope, 1 week on the inpatient side and 3 weeks on the outpatient side. Huge win for us, I think it's a huge win for them. And as we did it in the past, there was a outpatient opportunity for a pediatrician and an inpatient opportunity for a pediatrician. So somebody who wanted to keep their skills to do both, and by the way, save us a whole physician FTE, those are the kind of things that we should look at and do every single day. And I think that's my commitment. I think it's Greg's commitment. I think it's everybody's commitment. And I think we're actually at a better spot now than we've been in the 2 years or the year and a half that I've been here. So we're hoping that would produce some significant positive results.
Yeah, because just to that point, I mean, it's easy to blame people, but I mean, you got to look in the mirror every once in a while and say, hey, are we doing the best that we can be doing together? And I don't think that happens. I mean, that's why I applaud this. And I mean, it was contentious. It's getting a lot better. And I think that's the goal for me is, because it's a lot to learn. I mean, I'm in 15 months in this, and I mean, and I'm on health plan and getting all of those pieces together and the quality scores, which I guess he's going into next. I mean, it's a lot to understand for a layperson. So that was my comment to the boards, is when you have folks, so we split it off, and then, those people have to be subject matters too, like I have to be a subject matter too. And it takes a long time to get up to speed, and I'm still probably asking the same questions because I don't understand it. But I think that's important because that's the type of governance that we have. I mean, we can't change that. So we rely on you guys for the expertise, and sometimes it just got a little muddy to whose job was what. So now that we've gotten all that figured out and we're playing fair in the sandbox, and I think it's the patients and the taxpayers that we need to be mindful of, because sometimes we get, it's your fault, and I don't think anything comes of that. I mean, we figured out whose fault it is and how much money we've lost, but I think it's, the steps that you've taken to the hospital. I mean, I can kind of see why the losses are the way the losses are, because there's so many variables that you can't control. So how do we get better at controlling those variables is the questions that need to be asked. So thank you.
Well, I'm not competitive, but we didn't have a loss last year. I just want you to know, we did not have a loss last year, and it doesn't look like I think we're gonna be able to avoid that this year as well. But we can do better. I'm just wanted to go on the record.
No, but I mean, it's important that, you see that and you justify it and you figure out how we're gonna fix it. And I mean, because there are so many variables that keep moving, and I'm learning them as we go forward. And I think those are the things on how, as an organization, as an employer is the other part of it too, is how we fix that so that we're more competitive, I mean, and just just because doesn't work. You know what I mean? It's kind of frustrating. But there's things that have been status quo for so long and they don't change overnight. So, I mean, that also needs to be, we need to be mindful of that we're not gonna change it overnight, and that everyone who is involved needs to be players and fix it, you know, collaboratively. So I'm in favor of you guys hashing it out and coming quarterly, so thank you.
Brandy, have you worked with my office with regard to this proposal?
We have not.
Okay, I'm just, it'd be good to do so, just because we want to make sure, as you're aware, there are Broad Act implications to having what is essentially an advisory committee or a workshop. And so let's talk offline just to make sure
Yeah.
we've got all the
So
Ts.
the idea today was this was an informational and discussion item to get the feedback, and then we would come back with a formal agenda item at the next meeting, so we can work over the next month for whatever specific steps we
Got
need
it,
to
so this
follow.
is just discussion at this
Just
point?
discussion.
Okay.
There was a chance that the idea would not be favorable, and
There's always that
then we
possibility.
wouldn't need to move through all the other steps.
Yep.
Thank you. Are there any other board member feedback? Okay, I'm gonna turn the mic over to Ms. Regallo. Thank you.
Thank you. So we won't, and I'll ask council, do we need a vote just to even have the opportunity to take a look and discuss this?
You could do a motion to direct staff to look into this possibility and bring it back.
So I motion that we take into account the subgroups and meeting quarterly.
Second.
We have a motion by Supervisor Canepa, second by Rick. Sorry. And all in favor?
Aye.
Aye.
All opposed? Okay, motion passes. Thank you. Moving on to our next topic, and the presentation will be done by Mr. Greg Diederich, and it's the preliminary quality scores and background for the QIP program.
So I think the presentation's going to be
Yeah.
done by myself and
Correct.
Dr. Dulio.
So
Oh, well, okay.
Chris Zuniga will do the kind of the financial implications of the QIP pool, and Dr. Dulio will do kind of the metrics.
Thank you.
All righty, folks. Well, good morning again. We are going to focus this presentation on our Quality Incentive Pool Program. We are short on time, so we're going to try to run through as quickly, but also as clearly as we can, so that the information is well received. Today, we're going to discuss programmatic and fiscal overview. I'll be doing the fiscal piece. Dr. Dulio will talk about prior performance, PY6 measures and performance, our performance improvement, and then the challenges that we've observed running this program for several years. So the Quality Incentive Pool Program, otherwise known as QIP, this is sort of dollars that the state is flooding the provider space with. These are efforts that are approved by CMS, that is federally approved, and they're known as directed payment programs. And what that means is that the state tells or directs the health plans how to dole out these funds. So these funds come from the state through our health plans and then to the providers. This particular program is a public sector program. And this is not, by the way, an FQHC concept. This is a public health system concept. And so these funds are calendar year based. They are the successor to the PRIME program, which is another acronym, but essentially all of this is under the umbrella of practice transformation, and that's the point here. Healthcare across our country, and indeed within our state, is trying to transform the way we deliver healthcare and why we deliver healthcare. What do I mean by that? We want to catch the 4'2", 500-pound patient before they become 500 pounds. Guide their life in the outpatient setting so that they don't end up in the inpatient setting. These funds are earned in the outpatient setting for the most part. And that's what we mean by practice transformation. We're not talking about acuities and, hoping that we upcode so that we capture dollar. This is seeing our patient population and managing that patient population in the outpatient setting primarily, not entirely, primarily, so that we don't get to those situations where we have our patients in our hospitals for 700+ days, as we've heard in this committee. So this is just one of several programs that the state is flooding the provider space with, both public space and traditional providers. This one just happens to be a public space sort of idea or concept payment scheme. This is all managed care Medi-Cal population. This is not traditional Medi-Cal. This is managed care Medi-Cal population. Again, the money comes from the state through the health plans to the providers.
San Joaquin Health is a Medi-Cal managed care program. All of their members are what we're including here. So that's what he means by Medi-Cal managed care, as opposed to somebody who's fee-for-service Medi-Cal, not attached to a system, and just goes in for episodic visits. Does that make sense?
Yeah, so then we also see these at the health plan. So what, are they the same numbers? So I mean,
As in the bottom part of the slide, 47% of the QIP measures have a overlap with the HEDIS measures, so there's a lot of overlap.
so what we see there overlaps here, so 47, so 1 and 2 people are in both places?
No, so as mentioned, the population that are subject to these incentive pools are only the managed care patients, Health Plan of San Joaquin, Health Net, a little bit of Kaiser. But the measures we're looking at for QIP, 47% of those fairly overlap with HEDIS measures. And at the health plan level, we talk about the HEDIS measures, the 50th percentile, getting sanctioned if we don't meet those measures. So a lot of overlap with the measures themselves, colorectal cancer screening and such.
So then who makes up a non-managed care Medi-Cal member? What are those people?
Traditional Medi-Cal patients or other payers entirely, like Medi-Cal, commercial, private insurance. Those are outside this demographic.
So
Okay.
those are foster children, individuals that just became eligible for Medi-Cal, will be on a fee-for-service until they get assigned to a managed care plan. But in our county, that's probably between 1% and 2% of the whole Medi-Cal population.
Okay, thank you.
So Mr. Dietrich mentioned HEDIS. That is another acronym. We love our acronyms here. Healthcare Effectiveness Data and Information Set. Those are quality metrics that are used by 90% of U.S. health plans for quality reporting across the nation. So 47% of the metrics we use in our California system called QIP come from this HEDIS sort of national metric, quality metric sort of standard, if you will.
So then the hospital has HEDIS measures or just the clinics? So
Our
this
patients-
is for the QIP?
Our patients have HEDIS measures, and our patients belong to both the hospital and the outpatient setting, FQHC.
So that's why it's more important that we do better together.
Correct.
Okay.
Just really importantly, if you look at CMC, for example, they're a federally qualified clinic. They have to operate under the same measures that our clinics operate, yet they have no ability to collect these public funds. The public funds are significant to health systems that have FQHCs along with hospitals.
Obviously, the 17 participants that's in the next slide. Okay, thank you.
Right, but sort of piggybacking on what Rick just said, CMC does not participate in this program, so the quality metrics that are associated with our patient population and this program, apart from the HEDIS, which is sort of 90% of the nation, apart from the 47% that are universal quality metrics, are specific to us. So they wouldn't know exactly what those metrics are. They don't have visibility on that. The Quality Incentive Pool Program currently has a gross pool amount of $1.9 billion. And that's a gross number, and I don't want it to get confused with the net, because the gross is not what, the state sees. It's sort of the value of the input of the players, the skin in the game, and then what's being doled out by the state through the health plans. There's only 17 participants that are sort of working to earn these dollars. 5 of them are UC Health Systems, and 12 of them are counties. There's only 2 primary drivers of these dollars. One is sort of the patient seen or assigned during a calendar year. That's something we report. Apart from that are the quality metrics that Dr. Dulio is going to talk about in a little bit. Okay, but it doesn't get more complicated than that. There's 2 pieces. How many patients we see, and that determines what we call the pro rata gross pool share. And then the metric performance determines of that gross pool share, how much did we earn? Pro rata gross pool share. That sounds like a fancy term. It's not. That means of the 1.9 billion, what percent in terms of the patients that we saw in the state, right? What percent is that done in San Joaquin County? The answer is typically around 3.5 to 3.8%. LA County has the largest share, as you might expect, at 23.7%. The UCs, they don't account for much. UCSF has the highest sort of pool share at 3.3%, which is less than ours. Other examples are San Mateo at 3.1, Alameda at 5.6, Natividad, otherwise known as the County of Monterey, 3.5%. Okay, so this is spread out across the 17 participants, but LA County definitely has the lion's share. And again, so there's 2 pieces, the patient seen and the metrics. The metrics say, okay, San Joaquin County, you're eligible for 3.8%. That represents a certain number. But your metrics of that number, that 3.8%, how much did you actually earn? And therefore, how much comes to us in a net amount to the county?
So how do they take into consideration different areas of people live healthier than other areas?
They don't. So the metrics are the attempt to normalize a patient as if a patient in
Monterey County is the same as San Joaquin County?
That's exactly what I was going to say, Supervisor Canepa.
So it's touch and feel. I mean, you touch the patient, you go.
You touch the patient, you golden. And wait a minute, and
Well-
you document for it. And you document for it.
And the patient follows through, right? So just touching them is not enough. For example, if it's breast cancer screening, they actually have to do the mammography, or they actually have to have their hemoglobin A1C less than 9%.
So I'm going to get into the nitty-gritty sort of calculations for net revenue. It's not that complicated, but I also know that we're short on time. Okay, so we have our pro rata gross, what we just talked about. But that is not what the counties earn. The intergovernmental transfer, otherwise known as our skin in the game, or if you're familiar with grant programs, it would be analogous to a match component. That's what we contribute to the 1.9 million. And that's generally about 30%. So of that 1.9, 30% is contributed by the participants. And then the state sends us through the health plans the 100%. And so the net revenue is that 70% times multiplied by the quality metric performance. And that gets you your net
So
revenue.
it's pay to play.
Pay to play. You got it. Now, this slide is very important because it talks about sort of the realities that occur in any given year. A program year is a calendar year. We just covered that a couple of times. So January through December 31st. But the following calendar year, we report those two drivers. One, the quality metrics are reported in June. The patients seen are reported in September. The following calendar year, in about February, we get our intergovernmental transfer bill that the hospital just finished paying in February. And then in like March or late March, early April, the health plans send us our payment as a result. And so you can see that the program year itself occurs almost, 15 months before the payments are dispersed. And folks, accounting occurs during this whole period. So, for example, today is March 20th, 2024. We just submitted the IGT, Intergovernmental Transfer, our 30%. Our bill, we just submitted that to the state for program year 5, otherwise known as calendar year 2022. That will be paid out through the health plans sometime in the next few weeks, like the distribution. But also, March 2024 is the third period in program year 7, otherwise known as calendar year 2024. And also, March 2024 is 3 months away from when Dr. Dulio is going to report the final results. If I haven't confused you, I'm going to right now. The final results of calendar year 2023, otherwise known as PY6. We're always working on multiple years. We have our visibility on multiple years all the time under this program. So that piece, that sort of dynamic is real, and we live it annually. So we need to be predictive and conservative in our predictions for revenues, for performance, et cetera, because we won't know for 15 months what we actually get. All right, so now I'm going to get some numbers on the screen, and we've got 5 minutes left, so Dr. Dulio has several slides. Folks, we emailed the supporting schedule that goes along with this summary schedule, and this is our historical performance for QIP as a county. But it's our historical performance for QIP under the auspices of a lot of flexibilities from the state. The state gave flexibilities to participants that allowed us to earn these funds and not necessarily perform on our quality metrics. If you see program year 1, otherwise known as fiscal 18, through program year 5, otherwise known as calendar year 2022, all of those years have flexibilities or concessions associated with those performance years. The one-off, for example, the one-off for program year 5 was that whatever we didn't earn or our metrics didn't earn, we could actually roll that over into PY6, calendar 2023, and earn that in the subsequent year. We have a chance to make it up, is what I just said. So this model incorporates all of that, but as of calendar year 2024, there are no more concessions. You live and die on your metrics. This schedule shows that we have only realized about $2 million in unearned revenues throughout the history of this program going back to 2018. $2 million. Last month, we heard something to the effect of, this program is worth $80 million, and we are somehow foregoing $20 million, and that's just not true. And we needed to dispel those claims that were made last month so that everyone has the correct information. But also realize that the model we sent the hospital that produces these figures are for budgetary service reasons and conservatively estimate the future.
I don't understand how you can look at that chart and see the unrealized income of 14, 13, 14, and 2, in addition to the 9 million that's not on there, and say that our delta for public funds is only $2 million.
So he just said the delta of 9 million that is not on there. I have no idea.
The money we didn't earn, that we could have earned in 2024, was not earned.
In 2024, we're still in 2024. That's PY 7.
I have a question.
So what you're seeing in real time here, supervisors, is a lack of understanding of this program on behalf of senior leadership of the hospital.
Excuse
We
me,
have
Chris.
had-
Excuse me, Chris.
Okay,
That
hold
is
on.
so inappropriate.
Hold on. Obviously, we're going to be running out of time here. We want to, and we want to get through this, but we want to get through this respectfully. And this is the first time that I'm here attending, and so I would really appreciate if we can, if we want to discuss this, we're going to discuss it in a professional manner and allow everyone their chance to speak and answer questions. So, but I want to check on time as far as the supervisors. Do you want to proceed? Do you want to table this?
I'm fine on time. I don't have anything.
You're fine?
Till noon, yeah.
And how about the other board members?
We're fine on time. SJ Health is fine.
15? Okay, so Supervisor Ding said he has about 15 minutes. Are you okay with everyone else?
Got till noon, so whatever you want to do.
I'll cancel his other appointments, don't worry about it.
Okay, so we'll go ahead and proceed, but I do request that, I think Supervisor Canepa hit it on the head before. We need to collaborate. We're not here, we're done with the blaming. We do need to understand going forward, so I would appreciate it if everyone could just, you can go on with your presentation, but I would I would want, if there are others that would like to speak or question what you're saying, if we could just do that in a professional manner.
And our goal is to build some shared understanding, and it should not be contentious. And I think that the important thing here on this slide, when we're looking at calendar years 23, 24, 25, and it has those larger $13 million dollar amounts on there, we're budgeting performance at 75%, though we anticipate this coming in much stronger.
That's correct. Those are budgetary numbers.
So just one question, Chris and Greg. So annually, on average, the difference between hitting 75% of those quality metrics versus 100%, if I'm understanding correctly, 14 to 15 million over the last couple of periods?
So yeah, it's like 13 to 14 million, yeah.
And in looking at the quality metrics connected with all the other public health systems, as Rick alluded to earlier, 80% are hitting 100% of those metrics. I mean, they're not leaving any revenue on the table. So that's the only point we're trying to make from the hospital side. We have a huge opportunity at the county level to minimize that revenue leakage.
Well, I think that there was another point made or trying to be made in the citing of a $9 million number, which is.
Well, let's maybe move on to actually the actual quality.
I disagree. I mean, this isn't, and I understand we need to be respectful here, but we have a problem here, and this is kind of important to me. I need to understand where the difference of opinion lies here. It's probably more important than anything else we've discussed today, so I don't want to move on. I really want to know, I need an interpreter to tell me where the difference of opinion is.
And then I have a question. So it rolls over and then you get to track.
That's a one-year concession for PY5 only. We don't get that every year.
Okay, so your money not rolling over, so it goes back into the bigger pool. So now.
Yeah, so
Like
for-
extra credit when you don't do well on your test, so the
It's like
teacher
a
gives
makeup
you a
exam?
chance to make an exam.
Uh-huh.
That went
That's
away.
a one-year concession, though.
2023.
Or-
It rolled into 2023.
Yeah, so the PY5 monies that were not earned per the metric performance that the hospital were citing were allowed to be earned in PY6, the metrics that Dr. Dulio is about to report on, for the purposes of modeling and accounting and budgeting, et cetera, PY6 and every year after that. we assume 75% performance, just to be conservative on our accounting and budgeting. We expect to do a lot better than that. Dr. Doolittle is going to speak to that. But
Okay, before we move on, and I appreciate Supervisor Ding, you saying that, and this is what I was trying to say, I think we need to allow everyone to speak. And so, and I do think that, yes, you want some answers now. So before we move on, I know that you've addressed it a couple of times of what the hospital has said about the 9 million. And so, and I believe Rick was going to try and explain what you meant by that, and I think it would be helpful for the board members.
So they gave us another year because of the COVID to pick up what we didn't. That $9 million was, I forget what fiscal year, because it doesn't matter to me. It's all money that we should always collect at 100%. So when you look at those numbers, what we're trying to point out, which is accurate, is there's a $50 million numbers on the thing. I don't believe the 9 million for fiscal year '23 is on there, and I know that we did not earn all of that 9 million. Again, if the pot was 50 million and we collected 75%, and the pot turned into 59 million because we had another 9, you know, that it's a bigger number. My point always, guys, is if you look at, our goal should be what the other health systems are doing, which most of them are doing. As I said in the very beginning, we should try to figure out what that is, because no matter how you slice it, that's money that we should have earned that we did not earn. That's the important piece to that. I have another, I'd like to summarize at the end, but go ahead and give your presentation.
so I would suggest that the numbers that are purported by members of this committee be supported by source documents. This schedule was emailed to every member except for Sandy, with all support for these figures. So if there are other sort of calculations, then we need to know what the sources of those calculations are, just in general. Because if members of this committee start citing figures, it sounds really important because everyone here is important. But we need the source document. We need the calculation and assumptions that lead up to those figures, because that's exactly what has been provided for this work.
So I have a quick question. So then the 95% in fiscal year 2022, why did it take a 20% hit? So I mean, the net revenues percentage, right? Do you see it on that?
So you're asking, and I'll
Why
use that
why
little-
why are we down 20% and it's only projected when if you take a range of all those previous years, you're not going to be at 75%. So how'd you come up with a 75% net?
So I want to first point out the column that says projected actual, and
Okay.
only particular years up to PY4 are actual, realized, done years.
Oh, because we're a year and a half off on the numbers.
Yes.
Okay.
And also, there's that reality that exists every year, and then also there's a reality that calendar year 2022 was allowed to be earned in '23 for the portion that was not earned, that was found to be not earned. In other words, there's a concession associated with PY5 that is still not final, and therefore is subject to projection and assumption. It's not final yet.
So those have wiggle room is what you're saying?
Yes, sir. And we have estimated the sum total of our performance for PY5, inclusive of what is being allowed to roll over in PY6, to be 95% of those PY5 funds. Yes, we have metrics for PY5 that suggest we were at 78%, but the remaining award was allowed to be earned in PY6. So under our estimations, when you sum up the 78% reported for PY5 plus an assumed percentage which will be earned in PY6, that's how we get to our 95% and estimated unearned of 2.8 million for program year 5.
So I think this really highlights the need for the collaborative discussion so that we can have the meeting of the minds on QUIP and performance.
I agree.
One thing that I think is missing from this chart, and that we can talk about in further detail, goes back to Abe's point that this shows, as you said, Mr. Zuniga, this is 75% is what you're planning on budgeting. We all hope that we do better. But if 80% of the organizations are at 100%, this chart doesn't reflect what that number would look like. And I am trying to recap for all parties so we can remain collaborative. I think that is the point the hospital is trying to make.
So I don't think anybody at the FQ is arguing that we can't do better than we're doing.
And that's not what I intended at all to communicate, so I apologize if I did. What I'm requesting is perhaps could we add that to this chart so that we could see what the difference would be? If we were at 100%, what is that dollar amount?
That's the 14 million.
That's the 14 million
Okay, so I
essentially.
think then acknowledging that that's the hospital's point is that there's another target we could be trying to achieve, and that dollar amount is critical as well.
So I want to point out that the net possible award is featured in this column here. That's 100%.
I understand that. I missed that at first. My apologies. But again, I think the point is acknowledging that I don't hear in this discussion an acknowledgement that that is a number that the hospital is concerned about and the target we really should be trying to reach for, especially if 80% of the organizations are at that. I think that's what Mr. Nunes said.
Yeah, absolutely. What best practices are we leveraging here at the county level to get to 100% as other public health systems?
So those programmatic pieces are going to be Dr. Dulio's piece of the presentation.
Perfect.
So Dr. Dulio's going to.
Perfect. Thank you, everyone. So I'm going to kind of go in the nitty-gritty of what QIP is, how it's calculated, how we've done in the past, and where we're projecting we're going to be in the future and this year. So the first thing is, how is it calculated? So there are 40 measures, and for all intents and purposes, each measure equals 1 AV, which is achievement value. So each measure equals 1 point. So the 100% would be 40 points. There are opportunities to receive more than 1 point per measure. This is what we call overperformance. So there are 9 priority measures. So you can see right here, priority measures. And then there's, the rest are elective, right? So there's 9 priority and then there's 31 elective measures. They all require you to be at least above the 50th percentile. And then if you also have gap closures from the previous year, so if you're 15 to 20% gap closure, and it's a priority measure, you get an extra half a point. If it is an elective, you get an extra quarter point. If this increases to a greater than 20% gap closure, for the 9 priority measures, extra point, and then for the electives, extra half a point. And then just for the priority measure, if you happen to be above the 90th percentile, that's an extra point. So what are the measures, right? So they're broken up to clinic versus hospital. So of the 40, the vast majority are the clinic. And this is broken up into 8 sections. You can see here. So the highlighted are the priority measures. There's 9 of them. So that's primary care access and prevention, maternal and perinatal health. And then you have the electives, which are also primary care and prevention, and then care of acute and chronic conditions, care coordination, behavioral health, and then overuse, appropriateness, and experience of care. Questions? Here's the hospital measures. So there are 6 inpatient measures, and they're broken up into 2 categories, so maternal and perinatal health, and then patient safety. This slide depicts 2021, 2022, and then where we are right now for 2023. So 2021 was graded differently. So this PY4, you can see if we were graded across the 40 measures, our raw score would have been 56%. The reason we didn't only collect 56% is because you see this bottom right, it says COVID concessions. So PY4 only 20% of the measures were only graded on. So 40% was paid for performance. So out of the 40, 20 we were graded on. Then 50% of the collections was COVID-related questions, and then 10% were just the other 20 just reporting, not based on score, we got the extra 10%. So PY5 is when that changed to all 40 measures mattered, paid for performance. Even with that, our score increased significantly. So we went from 56% to 78%. And then for year 2023, we only have the clinic measures. We still have not received the hospital measures yet out of the 6. But if we were just to grade 34 points for the clinic, we're currently 30 out of 34. There's still a lot of time left in the year for validation, finding reports where patients went to outside clinics, had things done such as prenatal care. Patients went outside, had colonoscopies, or labs were outside at Quest, et cetera. So we're still validating the reports, but as of right now, for the clinic, we're 30 out of 34. And we expect that to go up significantly.
So these are based on being over the 50th percentile? Or this is
Correct.
dollar amount? So this is just,
Well, it would be both, right? So, but this is only out of 34 measures because we do not have the data points for the 6 inpatient measures.
and then what was that 10% in the bottom right corner? What does that mean?
Paid for reporting, that was for this year right here, PY4, right? So PY4, I think we're collecting 95%, but our actual raw score is only 56% because you see this bottom, it says 40% was paid for performance, so only 20 measures counted as far as performance-wise. And then 50% was related to COVID questions, and then 10% was paid for reporting. So the other 20 measures, as long as we reported on them, we received the points.
Okay.
And then that
was-
changed to PY5, whereas you had 40 measures, and that was all based on performance.
And what was the payout percentage on that year?
For which year?
Fiscal year 4 was still 100% then?
That was 100%.
Correct.
That was one of the
But
concessions.
it was graded differently.
Okay.
It was, the performance was only 20 measures.
And that was when money was allowed to roll over,
The
but now it
entire
doesn't?
state.
No,
100%.
PY5 rolled over.
Okay. PY
So, no,
okay.
we collected on PY4,
Okay.
but if we were scoring this the same way we do now, the score would have been 56%, not 100%, is the point I'm trying to make.
Okay.
So they use the year because of the COVID challenges to basically
Correct.
say everybody gets 100% that year. That's what they do.
And Supervisor Canepa, when you mentioned minimum performance level, that's generally a HEDIS measure. The way we get points in the QIP pool is by exceeding, growing 10% from the prior year. So a little bit different than the way HEDIS is scored.
It gets a little more complicated than that, but that I would say that's the easiest way to explain it. But again, right, so the key is 2021, 56%, 2022, 78%, and then 2023, just the clinic alone, we're already at 88% with still months left as far as validating reports, finding exclusions. For example, patient had a history of, hysterectomy. They shouldn't be on the cervical cancer need. So we expect this to keep going up. So last year, for example, for this year, we finished November, I think we were at 48%, and those next 8 months or so, we were able to get it up to 78%. So we expect this to go up.
And then one real quick, you said some of these are voluntary. What did that mean earlier? That they're not voluntary, right? If everyone's being judged on the same metrics, right?
No, there's not exactly. So there's 52 measures. You're judged on 40 that are already pre-selected.
Okay.
So we have priority, which are the 9, bold goal, and then the rest, the other 31, are what we call elective.
Okay.
But yes, those are known what they're going to be.
Okay, thanks.
So here's clinic measures not meeting target at this point. I kind of highlighted 4 of these just to show really how close we are, and our expectation is to meet these. So immunizations for adolescents, we're currently 3 away. And this is a lot of digging by our project managers, Vanessa, because a lot of our patients go to urgent cares and had the immunization already done, or they have exclusions, or they had it in our clinic and it just wasn't coded appropriately. Same with the well child, 7 patients away. In the postpartum care, again, 3 patients away. A lot of the patients assigned to us due to Medi-Cal, even when they're pregnant, they don't have to come to our clinic. So they go to CMC, they go to Dr. Gill's office. Back and forth for the last year and a half, finally got access to CMC records through their CEO and CMO, which now we're able to log into their system and search our patients to see what they had done. And then we're able to transfer the records to ourselves and then we're able to show that we're compliant. And that's 3 patients away, so we really expect to get those 3 patients.
So you get credit as long as that patient is served, regardless of where they're served?
Well, it's not just served, it has to be to spec, right? So for example, a C-section check has to be 7 to 14 days. If the patient comes in at day 6, that's not compliant. Or if they come in at day 15, that's not compliant. So the specs are very specific. So that's actually a lot of more work as far as the quality team having to kind of teach the outside physicians and the outside OBGYNs of the specs and proper coding. And then breast cancer screening, we're 2% away, which is, last year we were about 5% away. So, and that's a huge denominator, so that's a big stride. Some other ones I can talk about are chlamydia screening, colorectal cancer screening. We were the bottom 2 years ago, and we met both of those already. Chlamydia screening, we're above the 75th percentile. 10 minutes, so I actually only have 2 more slides. So performance improvement, this one's kind of hard to see. So I broke this up into 3 categories. So one is outreach and local managed care plan partnership. The other one is clinic documentation optimization and then data collection. So the first one, outreach, right? That's been a huge campaign. You know, we have 3 office workers that just do outreach, just in the quality team, call patients, let them know they're due for whether it be, you know, mammogram, colorectal cancer screening, et cetera. We also leverage that with standing orders that we've created, where if the patient agrees during that conversation, let's say for mammogram, the order is then placed in our EHR and proposed to the physician, and then I sign it. And what we're trying to do is do things outside the visit. Same thing with colorectal cancer screening, which we had our biggest jump in like a 14-month period. We use a system called Eye to Eye, which does a lot of our pre-visit planning. It lets you know what the patient's due for, where the care gaps are. We can also run reports just based on care gaps and use that list to outreach those patients. We do mailer campaigns. We also have Luma, which is a digital platform. It texts patients, let them know they're due for things. It also gives them reminders for their appointments at 7 days, 2 days, and 1 day before their appointment. Patients are also able to schedule through the text messaging, reschedule appointments, which is pretty nice. We have what we like to call internally Mammomania, which is we have the mammography van, goes to California Clinic. We do that on Saturdays. We've done 4 so far. We outreach patients that are due for mammogram, and we also outreach the patients that are due for cervical cancer screening, which Dr. Grace has championed that, and she does the pap smears the same time the patients show up for the mammogram. And just to give kind of the effort, so we usually call about 350 patients for mammography for a Saturday. Usually about 30 only agree to do it, and then usually about 8 show up. And this is even with talking to them 7 days, 2 days, 1 day, and then even same day, our director of quality will call the patients. 8 o'clock in the morning, just reminding you your appointment's at 9 o'clock. Yes, I'm coming, and then don't show up. So that there are some challenges, and I'll get on that in the next slide. And then we do leverage incentives with health plan, right? So we have backpack campaigns, which we have backpacks full of school supplies. We do that usually late spring, summer to try to incentivize parents to bring their kids in for well-child exams, and then we give them their school supplies. We also incentivize patients with gift cards. With health plan, they get $25 per measure. So for example, if the patient came in for mammography, had the pap smear, and had chlamydia screening done, they'd get 3 $25 gift cards, so $75. Clinic documentation optimization, that's the next. Again, gap clinic, gap clinic, gap clinics. We do so many gap clinics where we see what's due. We outreach these patients, and we have the clinics just to close care gaps. We've had revised ambulatory workflows from top to bottom, from front desk to medical assistants to the physicians to know whose responsibilities what, how we properly document and code to make sure we're getting credit for what we're doing. The quality department provides elbow support in the clinics, kind of walk everyone through how they're coding, how to code appropriately. We give feedback and we run reports on our employees and give that feedback, to kind of highlight the high producers and even the low producers to give education opportunity. Again, standing orders, as you can see here, there's quite a few of them, which has been our biggest care gap closure as far as breast cancer screening and colorectal cancer screening. We have flags within the EHR, so when you open a patient chart, you have flags that you know what's due that you can address during that visit. And this is through the health maintenance. We worked closely with HI, health informatics, to make sure these are accurate and up to date. We have huddles. These are occurring weekly, actually more than weekly with Rohini. She's our quality nurse. So she goes from clinic to clinic, so Manteca, French Camp, Stockton. She has these meetings with the medical assistants for proper coding, proper workflow, how to properly document. And then we also run reports, and we have our scores based on the employees. We have after-hours care, which is called Connected Care. This is 12 to 8. It's all virtual visits. During the sick season, they're very busy with respiratory illness. The other times of the year, it slows down. So we've trained their staff on gap closures, on, for example, depression follow-up, how we meet that measure. We give them a list of depression patients that need follow-up. They outreach those patients during the slow times and convert those to a visit, and then document and address the depression appropriately. We also have collaborated with Yvette at SJGH for radiology, for warm handoffs for mammography from the clinic, which has also helped with mammography. We have hired 3 coders, and you know, QAP is mostly code-driven. I shouldn't say mostly. We have to do the work. The work has to be done. But if it's not coded appropriately, you don't get credit, because there's no way that the state's going to go through millions of charts to make sure each thing's done. So it has to be specific code. So in addition to working with the clinics directly, the providers, the medical assistants, we also have coders that are combing through charts. When there's documentation that something was done, but it's the wrong code, they're converting the code to the appropriate code. And then we have, and then the last piece of that is we do leverage enhanced care management with John Cisneros, who manages our social workers, enhanced care management to outreach the patients to have social determinants of health, to see what may be a barrier for them getting care, whether it be they don't have a home, they don't have transportation, whatnot, which has helped quite a bit. The last piece on this slide would be data collection. So constantly validating reports, and this is whether it be internal reports or reports from Health Plan of San Joaquin. There's the reports we initially get are usually not very accurate. They're not, you know, either patients aren't in the numerator that should be, or patients aren't being excluded that should be. You know, we do have interfaces with Exact Sciences, which is our colorectal cancer screening platform. We use Cologuard, and we're able to go on the portal to see patients that had it ordered in case they weren't uploaded into Cerner. We can double check to see if it's actually done, and we're able to, you know, find more patients that go into the numerator, which has been, which again, our biggest uptick in colorectal cancer screening went from the bottom to already meeting that measure. This is the same thing with Quest. You know, for example, chlamydia screening, most of the patients go to Quest. It's not as clean into Cerner as if patients had labs done at SJGH. SJGH, the chance of it ended up in Cerner on the patient's chart is near 100%. It's not the same for Quest. So we constantly keep a log of chlamydia screens that were done, and then we have our project managers routinely going into Quest and individually search those patients to see if there was actually a chlamydia screen done. Where am I? And then RIDE. RIDE is, am I out of time? Okay.
Let's go over the challenges.
Sure, I'll go to the next slide. So challenges, right? So again, the biggest piece is a large assigned, not seen patient population. You know, we have 47,000 assigned lives. About 17,000 of those seek care. So these patients count towards our denominator, whether they come or not. So I mean, a lot of these measures have to be done annually. So the beginning of the year, you know, whether it be April or so when we do our new refresh, everything's gonna look like we're doing quite poorly because January 1st it refreshed. So we're constantly hounding the people, or the patients, I should say, the first quarter of the year to get in, get the depression screening, get their tobacco screening, and get their chlamydia test, et cetera. But again, unengaged and non-compliant patient populations, even when we talk to them the same day, an hour before the appointment, still tend not to show up. 350 patients to 30 scheduled to 8 showing up, and that's expected. Data gaps, so lack of external data. Kind of talked about that. Quest, outside physicians, whether patients are going to CMC, whether patients are going to Dr. Gill's office. We're constantly talking to their medical staff, getting access to their EHR to pull the reports. And then we have delayed and inconsistent data sets. So, and this is from health plan, we still don't have our final patient population for 2023, and we're in March now. So, and that's why we like to be conservative as far as what we expect to get, because the next refresh can be, more patients that were assigned maybe in December that we actually did not see this year, or last year, I should say. Other challenges, so operational clinical staff, so quality documentations, elbow support, day in and day out in the clinics, making sure we're coding appropriately, we're coding and getting credit for what we're actually doing in the clinics. Patients being scheduled outside the measure window or being seen outside the measure window. I talked about the C-section check. If someone comes at 5-day, that's too soon. We're not going to get credit. Or if someone has an appointment, let's say in 10 days, and they reschedule for a week later, what happened? There you go. A week later, they're going to be outside the measure. Hybrid provider buy-in. I'm optimistic that's getting better. I've had very productive meetings with Dr. Jaffrey, who's the chair of family medicine. She's on board to improve the hybrid provider quality of coding and quality of care. Hybrid providers are the ones that have a footprint in the hospital and the clinic, not solely in the clinic. And the timeframe challenges, kind of talked about. The patient's not seen this year, they're not getting credit. It didn't happen, right? So every year they have to have body mass index, they have to have tobacco screening, they have to have depression screening. So if the patient didn't seek care or missed a few appointments and did not come in this year, they're going to be a 0 on the numerator for all those measures.
So Dr. Dooley, I think
yeah.
we're pretty much
Yeah.
at time.
That's the last slide.
And I think the quality has drastically improved.
Absolutely.
There's opportunities to continue to improve that, and I think it really requires shared understanding and partnership. But I think you've done an excellent job in moving this needle. We're going to close some gaps, and with that, I'll turn it over to Ms. Regallo.
Thank you, and thank you, Mr. Zuniga and Dr. Dulio. I think it would be great if we could probably, I know that the hospital probably didn't have the opportunity, but to have enough time to prepare, but if we could see, I'm guessing the board members would probably want to see both sides, so we can see as a whole how we're doing, because I believe this was just reported for the clinic side, right?
No, that's not correct. That's the
Oh, I'm
whole
sorry.
county.
This is also including the
The
hospital.
inpatient piece is included.
Okay,
Just not for 2023.
okay, not for just this.
We do not have those numbers from the
Okay, and that's
hospital.
what I was referring to. Okay, so then only for 2023, the 88%, is that what?
That's only for the clinic.
Only for the clinic?
Correct.
Thank you. So it's only for 2023. So moving forward, then hopefully we can just get all the years that include both data. Any other comments on that? Seeing none? Okay, the next one we have on the agenda is public comment. Annette, can you tell me if there's any public comment?
There's no public comment.
Okay, thank you. And moving on to committee comments, does anyone have any comments?
So, you can tell I'm passionate about this. I don't think that we did the right way of separating the clinics from the hospital. But we're working, much more collaboration, much better scores. I think, though, what has occurred over this whole ordeal is we have a board that is associated with the clinic that has been given information, usually on the positive side. They think they're doing very, very well. So I would like you guys to, we know we've put a lot of pressure on the quality, and you guys have stepped up. Thank you, Dr. Dulio. Those numbers, when we get to 100%, is what we need, because to me, that's still $50 million that the county could have, and I hope we can all agree to that. But I also think we need to take a look, a very detailed look at the cost structure, because the clinics under the hospital cost structure was about $21 million. And there's some things that maybe we don't understand, or maybe we do. As the clinics are tracking right now, 3 years later, that cost is somewhere around $48 million. So we've gone from 21 to 48, and I would like to understand that, because what we do know is outside of the QIP funds, the potential revenue for the clinic sits somewhere less than $25 million outside of those quality funds. And I give CMC as the example because they're the competition, they're in the community, they don't get QUIP funds, and they run at a positive. So I think it would be a dereliction of duty not to try to understand how we've gone from a $21 million cost base to what's tracking now 2 years later, or less than 2 years later, at $48 million. I think that's really important. Thank you.
For the record, that $21 million number that the hospital CEO just cited is not supported by hospital audited financials or FQHC audited financials. And I can show what the actual number is with support.
So just going forward, those will be the things that will come into conversation.
Correct.
So that I can get the number
But-
and then I can make the best practices, you know, and what's
Shared
going
understanding
forward.
is
Yeah,
what we
because I mean, that's even more alarming, the quality measures that you're trying to do. I mean, besides the doctor going to their house, I don't know what else you can do to do that. And I mean, they will pick up patients, which is even more alarming, that the people that are trying to get preventative care. So, I mean.
And that's a barrier for our county. You know, I participate in the California Healthcare Foundation Fellowship. It's a 2-year fellowship, very competitive. They only accept 32 people. So my colleagues in this fellowship are CMOs at other institutions. And for example, they may have 27,000 assigned lives and 26,000 seek care. And that is very specific to here.
Any other comments before we wrap this up? Okay, seeing none, there are no closed session items scheduled for today, and we will go ahead and adjourn. Our next meeting will be on April 17th, and then we'll decide going forward in there, and adjourning at 10:36. Thank you.